to continue our section. So please be patient and join in our discussion later, okay? And continue our focus on robotic applications. We are now joined by Associate Professor Chung Hsiao-Jen, Director of the Division of Urology at Taipei Veterans General Hospital. So let's welcome. Thank you.
Excuse me, how to use this one? The next one, okay, the previous one, and the laser one, okay. Thank you very much for your kind introduction. Dear Superintendent, dear guest, dear colleague, ladies and gentlemen, my name is Hsiao-Jen Chung. It's my great honor to be here and to give a talk. The topic I give today is robotic surgery for urological cancer. I will share the experience of hospital with you. I have no conflict of interest. These are the outline for my talk. I will talk about the robotic surgery program in Taipei Veterans General Hospital. Then I will introduce you the robotic surgery in the urology department. Then I will share the experience of our laparoscopic, robotic assisted laparoscopic radical prostatectomy and the robotic assisted partial nephrectomy with you. Okay, first, the robotic surgery program in our hospital. The program is started in 2009. So we established the first system in our hospital. That system is also the newest one, the SI Da Vinci surgical system. It's the newest at that time, and it's the first SI Da Vinci surgical system in Asia. So we use this system to finish the first radical prostatectomy and the first partial nephrectomy. Then we bought 3 XI Da Vinci surgical systems in 2017, 2021, and 2024, respectively. One of them is the dual console system. In the last year, in my hospital, we finished 920 robotic surgeries. We are proud to say we have the highest surgery amount per system in Taiwan. We have sufficient patient volume, and we have high efficiency. This is the first one, Da Vinci SI surgical system. Actually, this system is retired in 2021. So we now, in my hospital, we have 3 XI systems. In the beginning, we realized that the robotic surgery is the way to go in minimally invasive surgery. So 2 years later, after the establishment of the first system, we have the first version of our robotic steering committee. This is now the structure of our robotic steering committee. This committee is led by Vice Superintendent Professor Zheng. Now I'm the president of this robotic steering committee. We have 5 subcommittees. The project development section, the data analysis section, public information section, clinical development section, and surgical nursing section. And the main task of the project development section is the short-term, mid-term, and the long-term strategy development, and also integration between different sections. And the main task of the data analysis section is cooperation with the IT technology to perform data collection and the data analysis. The public information section, they will do the patient education through website or through newsletter. The main task of the clinical development section is the young staff training for the multi-specialty development and the basic training program TR100 follow-up. And the surgical nursing section, the main task is for the nursing staff training and the refresh. In my hospital, almost all surgical divisions will perform the robotic surgery. For example, the colorectal surgery, the general surgery, the cardiovascular surgery, thoracic surgery, ENT, urology, gynecology. Okay, I will introduce the robotic surgery in urology. After the establishment of the first surgical system, we urologists all give our intention to develop the robotic surgery. So as you can see, the surgical number is increasing every year. In 2025, the last year, in the urology department, we finished 498 surgeries, almost the half of in our hospital. So from the first system to the end of the 2024, we finished 3,727 operations. Most of them is the radical prostatectomy. So the radical prostatectomy, 2,154, partial nephrectomy, 838, radical nephrectomy, 61, nephrectomy plus bladder cuff excision, 332, radical cystectomy, 75, nephrectomy plus cystectomy, 14, pyeloplasty, 47, adrenalectomy, 37, others, 159. So I will share the radical prostatectomy, then the partial nephrectomy with you. From December 2009 to December 2024, we finished 2,154 cases by 70 surgeons. In the beginning, we used the transparent peritoneal approach with the 6-pole assignment, the surgical procedure briefly, endopelvic fascia dissection, PP ligament, and the dorsal complex excision, then the nerve sparing by case, and so forth. But my personally now will perform the radical prostatectomy with endopelvic fascia sparing, puboprostatic ligament, that means PP ligament sparing, and the dorsal vein complex sparing. This is pore site assignment, 6 pore. The mean age of patient is 67.3, mean body mass index 25.2, mean ASA score 2.1. The mean consult time was 263.1. Mean estimated blood loss is 110.6 cc. There were only 35 patients need to be blood transfused, that's 1.6%. The folic acid can be removed on the 5.7 postoperative day, and the mean postoperative hospital stay is 6.1 day. We use the Clavian-Dingo classifications to grade the surgical complication. Briefly, the grade 1 is deviation from normal, no need for treatment. Grade 2 need pharmacological treatment. For example, need blood transfusion. The grade 3 need surgical or endoscopic or radiological treatment. The grade 4, life-threatening complication, grade 5 death. The grade 3, 4, and 5, they will call the major complication. So the complication rate within 90 operative days overall is 29.7%, but most of them are minor complication. The grade 1 complication, 24.8%. For example, minor leak, acute urinary retention after Foley removal, excessive drainage amount, paresthesia, ileus, intestinal minor injury, for example, serous injury, repaired intraoperatively, pubic region ecchymosis, gross hematuria, wound fat necrosis, acute gout attack, subtracheal injury during Foley catheterization. The grade 2 complication rate is 2.3%. Most of them are blood transfusion. But we did experience some major complication. The grade 3, 2.5%. For example, acute urinary retention by blood clot and the need blood clot evacuation in the OR. The deep vein thrombosis, compartment syndrome, and the lymphocyte need to be drained by radiologist, pulsi hernia, ureter injury, rectal injury, vesical rectal fistula, bowel perforation, bowel obstruction, internal bleeding, subtracheal injury need to be open to repair, and wound infection, but only 2.5%. The grade 4, only 0.05%. There's no grade 5 complication. This is our oncological result. The final pathological stage, PT2, 1,029 patients. PT3, 1,120 patients. PT4, 5 patients. The surgical margin, the overall surgical margin, positive surgical margin rate is 27.7%. The PT2, that means the cancer cell is within the prostate capsule. So actually the positive margin rate in PT2 is the surgeon's responsibility. But in PT3 and the PT4, the disease is already extended extra capsule. So the positive surgical margin rate in PT3 and PT4 will be high. So the PT2 positive surgical margin rate, 9.4%, 4% actually is the average worldwide. This is our functional results. The continence rate, almost half the patient. Strictly speaking, 56.8% patient experience urinary continence after removal of Foley. And almost 1 year after surgery, the rate is approaching 90%. Okay, next I will share the partial nephrectomy with you. In the 2004, this is in my early stage of minimal invasive surgery, and I just finished my fellowship training in the California, and after my fellowship training, I started to develop the minimally invasive partial nephrectomy. At that time, it can be only used the laparoscopy. Use laparoscopy to perform partial nephrectomy is very difficult because you need to handle the intracorporeal suturing in the limited time. So as you can see, once we have the robotic system here, this kind of surgery converted from the laparoscopic to robotic. And the operation number is obviously increasing every year. These are the key points of this surgery. We almost always use the perioperative imaging, especially the 3D reconstruction CT image, to detail evaluate the renal vasculature and the tumor anatomy. And we control the pedicle during the tumor resection, and I personally will recommend to do the pedicle control because adequate pedicle control provide a clear operative field, so we can excise the tumor without leaving cancer cell in patient. For the difficult case, we will use the intraoperative ultrasound to appreciate the tumor size, tumor depth, and the adjacent structures. Then we can properly orient the resection plan. In the tumor excision, I personally will recommend use the cold knife only, so we can appreciate the different tumor structure. After the tumor resection, we have to perform the reconstruction and the check bleeding. So we use the innermost malleolus suture to close the clotting system and close the bleeder. Then we use the early unclamping technique, and we use the sliding clip renal rapid technique to shorten our warm ischemic time. So from December 2009 to December 2024, we performed 838 robotic assisted partial nephrectomy in 831 patients. 7 of them have bilateral renal tumors. 10 cases were converted to robotic assisted rapid nephrectomy due to we are unable to achieve the negative surgical margin grossly. We use the transperitoneal approach or retroperitoneal approach that depends on the tumor location. And we will control the pedicle use the co-incisor to perform tumor incision. The frozen section is used in only doubted cases. The hemostasis can be controlled by the suture and the tissue glue. So we have 828 cases for analysis. We use the two systems to grade the surgical difficulty. One is the renal nephrometry score. This system is used in the States. Another system, preoperative aspects and the dimension used for an anatomical classification of renal tumor. Briefly, Padua score. Padua score is used in the European Union. The mean age of the patient is 57.1 years. The mean body mass index 25.4. Mean SA score 2.0. 60.3% were male, and the right side renal tumor 51.8%. 10 cases were solitary kidney, that 1.2%. The preoperative tumor size, the mean tumor size is 4.0 centimeter. The mean renal nephrometry score is 7.6. The mean Padua score is 8.9. 73.8% was transperitoneal approach, and 93.6% patient need to be clamp the hyaluronic vessel. The warm ischemic time is 26.3 minutes, and 52.5% need to be repair the collecting system. The mean operative time 291.4 minutes, and the mean console time is 206 minutes. The mean estimated blood loss 257.9 cc. The blood transfusion rate 7.1%, and the post-operative hospital stay is 5.4 days. The overall complication rate 90 days post-operatively is 70%. And actually the major complication rate, that means grade 3, grade 4, grade 5, only 4.4%. The intraoperative complication is 6.6%, and the major intraoperative complication rate is 0.6%. The postoperative complication rate is 10.4%, and 3.9% is the major postoperative complication. The most of the postoperative complication, the major complication is arterial pseudoaneurysm needed to be embolized transversal, and urine leak only 0.5%. These were the final pathology of our patients. The malignant tumor, 72.5%, and the 27.5% were benign tumors. For example, angiomyolipomas, oncocytomas. In the malignant tumors, 98.8% were renal cell carcinoma. And the PD stage of this patient, the PD-1A, 66.3%, PD-1B, 17.2%, PD-2A, 1%, PD-2B, 0.2%, and the PD-3A, 50.3%. All these renal cell carcinoma, we achieved negative surgical margin. In the RCC patient, the mean follow-up is 60.2 months. We experienced the local recurrence in 60 patients, that 1.0%, and the distant metastasis in 12 cases, at 2.0%. This is the overall survival rate. The 5 years overall survival rate is 96%. 10-year overall survival rate, 92.8%. The cancer-specific survival, 5-year cancer-specific survival rate, 98.6%. 10-year cancer-specific survival rate, 98.6%. By the PD stage, this is PD-1A. In PD-1A, the 5-year cancer-specific survival rate is 99.4%. 10-year cancer-specific survival rate, 99.4%. For the PD-1B, 5-year cancer-specific survival rate, 97.5%. 10-year cancer-specific survival rate, 97.5%. The PD2 and the PD2A and the PD2B, only 7 patients. And luckily in this patient, we did not experience the death of our patient. So we actually is 100%, but as you can see, the number is too low to show the really survival. In the PD3A, the 5-year cancer-specific survival rate, 95.6%. 10-year cancer-specific survival rate, 95.6%. For the disease-free survival, this is the overall disease-free survival rate. The 5-year, 97.2%. The 10-year disease-free survival, 92.1%. In different stage, again, in the PD-1A 5-year disease-free survival rate, 98.1%. 10-year disease-free survival rate, 93.7%. In PD-1B, the 5-year disease-free survival rate is 96.3%. 10-year disease-free survival rate was 87.3%. Again, PD2A and the PD2B, the number is too low to show the really survival. In PD3A, the 5-year disease-free survival rate was 93.8%. 10-year disease-free survival rate is 89.8%. This is a functional result. In the estimated GFR, the preoperative eGFR was 87.8. The 6 months postoperative eGFR is 78.4, and the 1 year postoperative eGFR was 78.3. If we use the split renal function, the nuclear medicine renal function scan to evaluate the tumor site renal function, the preoperative tumor site renal function is 48.9%. The 6 months postoperative, the tumor site renal function decreased to the 43.4% and stabilized 1 year after the surgery. So the 1 year postoperative split renal function of the tumor site renal function was 43.4. So, conclusion. Robotic surgery for urological cancer is safe and effective. It has become a new standard for many urological cancer procedures. Thank you for your attention.